So my name is, as Amanda said, Kerryn Moolenschot, and I'm a paediatric dietitian that is currently working at St George's in London, and I have a special interest in EoE. And I am, as Amanda said, part of the working group for EoE. And today I'll be talking about diets for EoE in children and teens. So I just want to check it's working. Okay. Okay. So just a session overview. I'll just be talking about definitions of EoE. Just as a recap, I'm sure most people here know what EoE is. And I'll also be talking about the incidence of EoE throughout the world. There's quite a few people, I believe, from around the globe here tonight. Treatment options for EoE, which may differ in different places, but I'll focus mainly on what I know around my practice in the UK. And how to pick a treatment, why diets are used in EoE, and what types of diets are used in our PEDS patients. So just as a quick definition of EoE, so ESPGHAN has quite an elaborate definition. So it's a chronic immune antigen mediated esophageal inflammatory disease associated with esophageal dysfunction resulting in severe eosinophil predominant inflammation. And just in more plain terms, it's basically a disease that affects the food pipe or the esophagus. And it results from people either eating food or being exposed to an allergen in the environment that results in eosinophils, which are a type of white blood cell, to congregate in the esophagus, which then causes inflammation and results in the symptoms you see in EoE. And how it's actually diagnosed is that normally a gastroenterologist will do an endoscopy and take biopsies of the esophagus. And then a histopathologist will look under the microscope and count how many eosinophils are within a certain area, so a high power field. And if there's more than 15, then it is a diagnosis of EoE. And also when they're doing the scope, they may actually see changes in the esophagus. Normally the esophagus is nice and smooth and pink and looks healthy. But in EoE, you might see inflammation, so like redness, abscesses, changes in the layering of the skin. So it might have different patches of skin, of the tissue. And also edema, so puffiness in the esophagus itself, and furrowing. So you may see lines going down the esophagus or rings going down the esophagus. And symptoms that that you'll see in EoE in infants and children are quite broad, so it makes it quite tough to get a diagnosis. And sometimes EoE won't be diagnosed for some time because there are other conditions that have similar symptoms. So what you'll get is reflux, vomiting, abdominal pain, food refusal, and failure to thrive in infants and children. And in teens, you may see non-swallowing associated chest pain, difficulty swallowing, so dysphagia, and food impaction, which is when the food actually gets stuck in the esophagus. And the symptoms above can then impact a child's growth and also their quality of life without treatment. So just in terms of incidence of EoE, so just some terms. So prevalence means the total number of patients diagnosed in the population. So over the entire period of time, if you take a point in time, there could be thousands of patients with EoE that are diagnosed and receiving treatment. And incidence is normally over a short period of time. How many new cases are you finding in the population? So per year in the general population, you normally have 1 to 20 new cases per 100,000 people per year. and just around the world in terms of incidence and prevalence. So in Iowa, there's an increasing incidence that they found, which might be due to more awareness of EoE. So it's gone up from 1 per 10,000 in the year 2000 to 4 per 10,000 children in 2003. In Western Australia, which I think there may be people here tonight, there's a prevalence of just under 1 per 10,000, and that was 2004 data. And then in southern Denmark, which seemed to be the lowest for whatever reason, there was 0.16 per 10,000 in southern Denmark of new cases of EoE per year. And it can also occur at any age, so from birth all the way through adulthood. And what they did is they checked on a nationwide registry in the Netherlands between 1996 and 2010. And they found that 20% of patients diagnosed were less than 18, so children and teenagers. And they also found on that registry that it's more common in males, so 74%. And they also, interestingly enough, found that the incidence of diagnosing EoE increased over time. And that's probably because people are more aware of EoE. So even myself, when I first started my practice, I didn't know what the condition was. But now there's definitely a lot more talk, and charities like EOS and working groups. So that's probably why there's increased diagnosis and awareness. And so it increased from a very small amount, 0.01 to 1.31 over the years in the registry. And also in the last 2 years of the registry, they diagnosed over half of the patients. So it just shows how steeply the diagnosis trend has gone. And patients with EoE do have a higher chance of having allergy alongside EoE, but there are two distinct conditions and are treated in different ways. But I'll talk a little bit more about that. And also celiac disease and EoE are also two independent disorders. There is obviously overlap between how they're treated, so like wheat avoidance, but they are diagnosed in different ways. And some patients may have both. So treatment options. So the goal of treatment is to reduce symptoms and also normalize what you find on the endoscopy, and also have reduced eosinophil counts. And with some patients, symptoms may persist even though you have normalized endoscopy findings. And that could be because of a very extensive disease, or children can develop behaviors from having to cope with the disease for such a long time. Yet they may just have hangover from that and have symptoms that carry on, even though their disease is in remission. So treatment choices, you've got proton pump inhibitors, or PPIs, and these are commonly lansoprazole and omeprazole. And in Europe, this can be the first choice of treatment for EoE. So before embarking on dietary exclusion or other medications, they may do a trial of PPIs first. And if you have remission, then you'll probably take long-term PPIs. But here in the UK, we do tend to offer a choice for patients. So you can choose a dietary exclusion, which I'll go more into, or you could choose swallowed steroids, such as fluticasone or oral viscous budesonide, or OVB. And at some centres, a drug, Jorveza, may be available to teenagers if the team applies for a funding or to be allowed to use it, because it's indicated for over 18 years of age, but it may be a treatment option for some teens. So as a patient, how do you pick a treatment, and also as a team? So you could choose any of the options that I've mentioned, but the treatment choice should always be discussed with a paediatric gastroenterologist or allergist. And it should be a shared decision with the patient. So as a child or teenager who may have a bit more of a voice, they will need to comply with the treatment, including long-term when you are doing long-term dietary exclusions, for example, and also the family. Expectations should also be discussed with the patient before choosing a treatment. So, for example, if you're embarking on a dietary elimination, the cost and availability of free-from foods could be a big factor in your choice. So GPs here in the UK aren't obliged to prescribe free-from foods to EoE patients on dietary exclusions. You know, alternative milks and gluten-free foods are more expensive, so that may be a factor for some patients. And also the timeline of the proposed treatment should be explained. So obviously there'll be gaps between waiting for endoscopy, time when you're on a diet or medication. And also children have events in their life, so there should be some planning around exams or holidays. So that should be taken into account with the teams. And any treatment that a patient chooses should be checked with a follow-up endoscopy after about 8 to 12 weeks to see if it's effective. So why are diets used? So dietary exclusion entails complete removal of a food or foods for a set period of time. And this allows the body to stop reacting to the food when it's eaten, which in turn reduces the eosinophil counts in the esophagus. And you would see that on a repeat endoscopy, and also symptoms. And then if you were to reintroduce the food and the eosinophil counts were to rise again, then it was a confirmed food cause of EoE, and you should exclude it from your diet indefinitely. So if dietary exclusion is chosen, then a patient should be referred to a dietitian in order to manage the diet. So I will talk about some diet options that we use in peds tonight. So the first one will be the elemental diet, which has a 90% success rate. The elimination diet, which is 74% effective. And I'll briefly touch on the slide on the food allergy testing guided elimination diet, which generally has a lower response rate than above, and is generally not implemented in the UK as treatment for EoE specifically. And the reason why is that skin prick and patch testing is not helpful in identifying the triggers of EoE, as it is a non-IgE mediated condition, which means that it's not like an allergy where, say, you ate nuts and you had an anaphylactic reaction, your body reacts immediately to the food ingested. It takes time for the eosinophils to build up in the esophagus. So you won't be able to test specifically for an allergen using these tests for EoE. But at my center, and I'm pretty sure at others, allergist referral is still recommended because patients with EoE do tend to have more allergies alongside the EoE. So, you know, 15 to 40+%. So it is good to have an allergist alongside a gastroenterologist managing a patient with both allergies and EoE. So luckily at our center, we have a joint clinic, and there are other centers that do this. So just with the elemental diet, so this entails a patient drinking an amino acid-based formula only. And this basically removes all food from the diet, and you're highly unlikely to react to amino acid-based formula. And it's very effective in getting quick remissions of 5 to 12 days. And that's in 90% of cases of EoE in children. So it sounds great, but it is the amino acid-based formula, and I know some patients have tried it from their pill. It doesn't taste very nice, so you may find that younger children and infants may take it better than older children and teenagers that are used to eating a good varied diet, although there are some exceptions to the rule. And patients that can't manage the full amount of their amino acid-based formula orally may need nasogastric tube feeding. So that's putting a tube through your nose into your tummy and feeding the milk through there, and then obviously training the family on using the tube. And the diet can be socially isolating for patients. So if everyone's sitting around the table and they're eating their food, it can be more socially isolating than an elimination diet, as they'll just be having their drink only. It can be costly, so depending on where you are in the world. So obviously we have the NHS and they do pay, but it is a cost to the healthcare service. But also in the world, it may be a cost to the patient, and these formula are not cheap. And long-term, there's low compliance rates, which is understandable as people tend to want to eat food again. And because you've done like a blanket removal of food, you don't know what the exact causes of the EoE. So as you reintroduce foods, there's a high likelihood you'll start hitting on the foods that the patient will react to. So in general, this diet is used more like a salvage therapy. So if a patient won't get into remission with an elimination diet or medication, then they may actually need an elemental diet just to get into remission, and some centers will use this. Then with regards to the elimination diets, and I'll also cover the step-up approach. So traditionally, centers using the elimination diet would do a 6-food elimination from the get-go. And this is removing the top six allergenic foods from the diet, which I'll go through. But you could also apply a step-up approach, which means slowly increasing how much food you're excluding in the diet, as most patients with EoE are actually react to sort of the top 3, and particularly cow's milk. So in theory, you could do a 2-food elimination diet first. Then if that doesn't induce remission, you could do a 4-food elimination diet. And then if that doesn't induce remission, then you go to a 6-food elimination diet. So you're stepping up the plan. So this approach avoids unnecessary dietary restrictions, as many patients only have 1 or 2 food triggers. And it also could potentially reduce the number of endoscopies the patient has. So for example, if you did a 2-food elimination diet, you did a scope after each food was reintroduced, you'd be looking at about 3 scopes, as opposed to starting with a 6-food elimination diet, where you're looking at least 6 scopes from the get-go. And compliance may be better in pediatrics, as parents manage the diet and the motivation for children. So they may actually cope better with the step-up approach than an adult patient would, whereas adults maybe would do better with just starting with the 6-food or have a definite plan rather than trying to motivate themselves through the steps. And the step-up approach also helps keep more variety in the diet, especially protein foods and foods that are rich in other sources like iron. So that can help protect growth and also reduce fussiness, as patients may not love the food alternatives that they put onto. And also some, especially younger children, may actually find it difficult to reintroduce a food if it's been removed. In terms of the 1-food elimination diet, there's not quite enough evidence to be in guidance yet, but some centers may trial a 1-food elimination. So for example, with a very young child that's mainly having a lot of milk in their diet. And it also could be when a patient has already a lot of restrictions, say they have a lot of food allergies and they're already excluding 2 foods, maybe just having 1 food might be worth trying first. And then internationally, other centers may trial additional food eliminations on top of the 6-food. But here in the UK, we generally just do the maximum of 6 common allergens. And the sort of thinking behind this is that for every food you take out, you're going to have to do an endoscopy. And also it's not currently recommended in UEG and ESPGHAN guidance, which many centers follow here. And some patients may actually have a non-food trigger for EoE. So you may take out lots of foods from the diet, but it might be actually something, an inhaled allergen, for example, that is causing the EoE in the first place. So just quickly through the elimination diets. So 2 food elimination diet, that generally implies taking out milk and wheat, which is mainly gluten-containing grains in the UK. And egg may also be chosen as the first of the 2 foods to be taken out, and that's as per European guidance. There's a common, one of the common triggers for EoE. And all exclusion diets should be tried for at least 4 to 12 weeks as per ESPGHAN guidance. And the 2 food elimination diet sees about 40% remission in children. And you may find in different centres and around the world, there may be differences in how people exclude foods. But generally in the UK, you'll find that wheat is excluded, including gluten-free wheat. So you may find products that have been deglutenized, but they still contain wheat flour. And the reason is that there is still other proteins in wheat that a patient may react to. And also other gluten-containing grains such as rye and barley exclusion. So we do generally a gluten-free diet. Then moving on to the 4 food elimination diet. So if you're stepping up, this is also known as the Muse diet, and it involves eliminating milk, egg, wheat, and soya from the diet. And this induces remission in about half of children with EoE. And interestingly enough, 3/4 of children had cow's milk as their main trigger. So that also feeds back to the 2 food elimination. Might be worth trying that first rather than embarking on a 4 food if cow's milk is the main trigger. And internationally, you may find that all legumes are excluded, not just soya. But in the UK, generally, soya is excluded. And then with the 6 food elimination, so the final step is the Muse diet, plus also removing fish and shellfish, and also nuts, including peanuts. And this is a very effective diet. It has a 3/4 success rates of 75%. So not too far off the elemental diet. And also out of 75% of patients only have 1 or 2 food triggers. So that means that most patients aren't actually reacting or don't actually react to all 6 foods. So it's important to reintroduce foods as you'll be doing unnecessary elimination, especially in children that could do with having some of those foods back in their diet, especially with regards to growth. So with regards to food reintroduction, you should follow an elimination diet for at least 8 to 12 weeks in practice. And that's normally the amount of time it will take to book in the next scope. And you'll need to, the team will then review the symptoms with the patient. They may even go through some scores. So like a pre and post questionnaire on how you're feeling and what symptoms you have. And then you should do a repeat endoscopy to see if remission was attained. And so basically to see if the eosinophil counts have come down after removing the foods from the diet. And foods should be reintroduced 1 at a time with a scope after each food is reintroduced. And a lack of symptoms does not always correlate with a reduced eosinophil count. So that's why it's always really important to have an endoscopy after you've reintroduced the food to confirm if it's a food trigger or not. So a patient may feel fine eating, bread and pasta and that again in their diet, but when you take the scope, you may find that the eosinophil counts are actually climbing when they've reintroduced wheat back in their diet, for example. And some centres may consider the step-down approach, which is basically moving the opposite way of the step-up approach. So it's starting with the least known food triggers, the ones that in the literature have the lowest percentage of patients that have it as a food trigger. So that's your nuts and fish. Then moving down to soya and egg, and then finally reintroducing milk and wheat into the diet. At our centre, we do tend to ask patients, what do you want to reintroduce? Especially you'll have some patients that are just desperate to have, wheat back in their diet or milk back in their diet. And, you know, we're happy to let them do that because it will help with compliance if they could get that food back in their diet. So it's not a hard and fast rule to do the step down approach. If a food that's been reintroduced causes return of symptoms and also the eosinophil counts rise, so the histology worsens, then it is a confirmed food trigger for EoE, and it must be removed from the diet long term. So any patient and their family that's embarking on food elimination as a treatment should bear this in mind. So it might be nice to know that a certain food is causing EoE, but the patient must then know that they can't actually have that food in their diet long term, and yeah, that should be discussed before embarking a lot of blood, sweat, and tears and endoscopies before finding the trigger. Also, at some life stages for children, for example, when you're you know, going into adolescence, may make compliance more tricky. So, you know, if you're a teen and you're out with your friends and they're all having McDonald's and, you know, you can't have the bun because, you know, you're not allowed wheat, can make it quite tricky. So that's another thing to maybe bring back to the team to help with compliance. And, you know, a dietitian can help discuss things, but also seeing if they really can't comply, what to do as the next sort of treatment. And just coming to the end, I obviously I've covered all the diets, but for the more practical stuff, you'll have to tune in with Lucy, who will do the how-to and the hot tips on how to actually do these diets. And thank you for your time, and I'll hand back to the team.
Lucy was asked about use of ketotifen, because it's quite interesting. When we've got some people around the globe, there is different approaches. If you would like to share that with us, Lucy.
Yeah, so I just said, generally in the UK, we don't recommend the use of ketotifen in EoE, specifically for the management of EoE. The patient might be on ketotifen, you know, for other reasons, but not for the management of EoE. And I just mentioned that the Lucendo paper really nicely kind of sums up using the evidence as to why, you know, why it's not used. And that's what most centres kind of are working from at the moment. I think you'd agree, Kerryn. Most people use Lucendo paper at the moment.
So I've also got some questions that have been submitted prior to tonight, which has been really useful. One of the questions that was asked, and I think this gets asked quite a lot, is the terminology of fish. And what does it, yeah, look, I can see you're laughing. You know, are we talking shellfish? Are we talking all fish? What is the relevance to that and the EoE diets, please?
So what we say is if we do a fish elimination, that's all fish, including shellfish. So that would be mollusks like, you know, mussels and prawns and, you know, calamari. So that's all fish. Yeah.
And any like fish stocks and you know, like fish sauces that you might use in Thai cooking and things like that, all of those as well. So anything that would derive from a fish.
And that kind of leads into another question, actually, and that was about how strict you have to be. You know, are we talking about may contain? Are we talking about things that have used it? I know you're probably going to cover a lot of this in your session, Lucy, but if you'd like to just give us a brief answer to tie us over in suspension until your full session.
Yeah, so generally may contain is allowed on an EoE diet. In terms of strictness of compliance, we don't know. Some patients appear to be able to have a little bit of like baked milk in their diet and it doesn't affect their eosinophil count, whereas others can't at all. So the blanket advice is really strict exclusion. You can have the may contain. But yeah, that is the general advice, because we can't, you know, tailor it for each patient because we just don't know what their threshold level will be really with those proteins.
Thank you. So another question that's come up is about obviously in paediatrics cutting all these foods out and the worry of reducing growth. What is the data that's out there on that, and how do you help manage it, and also deficiencies within vitamins, etc.? How is that usually managed?
Yeah, so I don't know if Lucy knows what about the data, but I would say any child that's embarking on an elimination diet is at risk for being deficient or not getting enough calories to actually grow. So that's why it's very important to have a dietitian to tailor the diet, because for every food that we take out, there are obviously nutrients that are, for example, milk will be calcium, or with your fish, you got your omegas and your protein. You know, there's a lot of iron-rich foods that get removed. So a dietitian can always tailor the diet and come up with recommendations, so like milk alternatives to replace the milk. Sometimes we do resort to multivitamins and minerals if we need to, but ideally we try a food first and give options with that. But sometimes you will need to take a multivitamin or a mineral supplement, and obviously always checking those supplements that they're also free from whatever you're eliminating.
Yeah, and I suppose just in terms of the data, so that I'm not aware of any specific growth data in EoE, but there's lots of data about multiple food exclusions, a lot by Roseanne Mayer, about how growth is affected with multiple food exclusions. I can't remember the papers off the top of my head, but I do have them. If anyone wants them, they can ask Amanda and I can email them over. So yeah, there is a lot of data that, you know, all these food exclusions do affect growth long term if they're not managed appropriately.
Do you find the other question is with these deficiencies and vitamins, etc., for those sort of extreme end patients who can't tolerate the standard vitamins and minerals because of binding agents, etc., do you find that you have to use the elemental feed to supplement it sometimes? Is that an additional way of doing it if there's no other way?
Yeah, so sometimes I suppose you'd only really want to use like an amino acid feed as an ONS, so an oral nutrition support, if there were growth concerns as well as sort of micronutrient deficiencies. I mean, we would normally start with an over-the-counter product that we'd ask families to buy if you're using a multivitamin or, you know, mineral supplement. But there are lots of prescribed products as well that are, you know, flavorless, you know, that are generally tolerated better. So we might advise that. There's also some really good sort of oral sprays now. I don't know if Kerryn, you use them, but I use them quite a lot. The vitamin D sprays,
Yeah.
and the iron sprays are really good. And they're especially really good in averse children. So they're quite a good thing to have in your toolkit as well if you're struggling to get a child to take a multivitamin and they have a certain nutrient that you're worried about.
Yeah, and they are very good, some of the sprays that have come out, but the challenge is always making sure on those ingredients, because I tell you what, the vitamins have some weird and wonderful ingredients. You buy them off the internet. It's quite a minefield with the oils, etc. I mean, that'd probably be a question for one of the latter weeks as well. So one of the questions that's come up now is about finding whether children actually, whether they outgrow the allergies, or whether they outgrow the EoE, and whether they're left with a number of problems into adulthood in your experience. I mean, obviously you only take them up into transition time, and how do you manage that?
So in our sort of practice, generally, once we've found what the trigger is, we just say, you know, indefinitely. I suppose I haven't seen it been outgrown, but maybe in time, if you hit adulthood and someone's prepared to do another scope and a reintroduction, then that would be an option. In terms of nutritional issues and food replacement, well, hopefully they've been on quite as a child, hopefully, you know, they've had enough nutrients to, you know, make sure they've reached a growth status that they need to got enough calcium and iron. But if even as an adult, I'd say just to make sure they've got a nutritionally balanced diet and are taking the vitamins they need. But not, and I suppose when they get to transition, which is also an interesting topic, it'd be good to have an adult gastro team, or if they've got allergies as well, an allergist involved going forward.
Yeah, I think, well, from what we hear in our sort of transition services, a lot of them don't have a dietitian to support. So a lot of the adolescents and adults will automatically kind of be switched over to a medical management of EoE. So I suppose it's just those conversations that need to be had. If the patient wants to continue with the exclusion diet, as long as they're managing it appropriately and they're not a nutritional risk, then there shouldn't really be a reason why they can't manage it long term, as long as they're meeting all their nutritional requirements and everything that they need.
Do you find generally, I mean, obviously transition, I can talk on a personal level on that. Like, it's quite a tricky period of time for many reasons, but do you find in your experience generally, especially for those that perhaps have had issues for quite some considerable time, it's a bumpy period in their management of their disease, because of multiple reasons, you know, obviously they're challenging everything at that period of time. And obviously that handover from parent managing, and you can see actually the change in how the adult disease has to be dealt with, because obviously you've not got the parent controlling and cooking and shopping and doing everything from that aspect. How do you support patients going through that period? What do you give them as advice during that time?
We try to. Oh, go on, Kerryn, you go first.
I'd say we try and start the conversation earlier. So not just you're about to turn 18, surprise. So hopefully, I suppose that's the time of diagnosis as well, which plays a part. But if you do start the conversation earlier, that does help. And just talking with the adult gastro colleagues that are going to be taking over. And also just speaking to, because they're teenagers at that stage, so they're often quite honest, well, most of ours are, and tell you about their struggles, what, you know, they want. Some are actually quite keen cooks, so encouraging to be a bit more independent, and also that independence even from an early age to just take some ownership. So, you know, teaching them about food labels, you know, starting to know what foods to exclude from an early age rather than the parent managing everything, just so when it does come time, then they have had some experience on managing their own diet. But maybe, you know, it's not a perfect system. I think it is an area that does need looking at. But yeah, if a patient does want to carry on with their food exclusion, you could always even speak to adult gastro, like dietitians, if you can, that may actually be able to take them on.
Yeah, and I was just going to say that we try to kind of, we have a big MDT clinic for EoE patients, and actually we try to, it sounds awful, but kind of boot the parents out a little bit when the children get to, you know, sort of 14, 15, and they can have their own voice a little bit more, because often they'll tell you things when the parent isn't in the room. So we had a patient who parents were telling us he's on a really strict milk-free diet, but actually it turns out that he was munching chunks of cheese straight from the fridge, but he would only tell us that when the family were not in the room. So actually it's really important to let the teenagers have a voice and be open and honest with you. And I think that's the best way to kind of lead into transition and allow them to start taking ownership of their disease and their condition that they have.
We know as an organisation it is an area that really needs some TLC, to say the least, both from a patient perspective and from a parent's perspective, and we hope over the next year that we can spend some time and energy focusing on that. And I know we've raised that as an area with the British Society of Gastroenterology, Paediatric Gastroenterology, because there has been some great work in other diseases within IBD, etc. And I think we could be a huge benefit and support to both angles, because it is a really tricky time, and often when they fall literally off the wagon, and it's nobody's in particular's fault, it's just a period of time. There was an interesting paper that came out of Seagear that they couldn't work out why there was an anomaly between the ages of 16 to 24, it might have been 18 to 24, I have to remember correctly, but actually the data dipped, as in there was a remission in the disease, and when they delved deeper into it, they called it the good times, because basically what it was a period of time that they just don't report what's going on. So of course all the symptoms seem to magically get better, you know. It's great, but yes, it's definitely a challenge, and we hope to be able to work on that. I'm just looking to see what other questions we've got here for you. So another question is, when a food is reintroduced, how long are they looking at before that it may rear its head with symptoms? And I know that it may not be symptomatic, as you've said, but if it is likely to show on the outside, how long should they be looking for before problems might start to arise?
So that can be quite varied with each patient. We've had some that literally within a week they're already complaining, and others where it will be all the way through until endoscopy and they haven't had any problem, and then you'll check. So it is very, very varied. I suppose you could maybe use a sort of ballpark of about 2 to 4 weeks, but it's very varied with patients.
Yeah, it comes back to this delayed non-IgE problem, doesn't it? And that it's not, it doesn't happen immediately, unfortunately. This is the complicated part of EoE, isn't it? That you can't see it, and you don't know when you're reacting to it, which can be quite a challenge, I think. And unfortunately, by the time you do get to see the symptoms, you're probably not in a very good way. So it's quite tricky from that aspect. I'm just looking.
Sorry to interrupt, Amanda. I've got a question that was sent to me, but I think it'd be fine to share. Are coconuts considered to be included in the nut exclusion? So coconuts aren't classified as a nut, so you can definitely use like a coconut-based, plant milk, or the coconut cheeses, coconut yogurts. They're actually really helpful in EoE, especially if a child's on a 6-food exclusion diet. So yeah, coconut is okay to have.
And I have to share with you this. I know it's not till the week coming when we do this. We've found coconut whipping cream. It's amazing, and it's perfect for putting on a cake and making it look like a real birthday cake. So yeah, that's a really big tip, and it's 100% coconut. So if you can tolerate coconut, it's a real gift. So I think now what would be nice, I think we've more or less covered most of your questions. I know, Matthew, we haven't covered one of your questions, but we will be covering that throughout the month of March. So I won't put that question to Kerryn and Lucy, and we'll hold fire to that till we get our gastroenterologists in the room to be able to answer those questions for you.